Dr. Oleksandra Kutsenko, who graduated recently as the IR Chief Resident from the Miami Cardiac and Vascular Institute, is currently a VIR at the Red Rock Radiology Associates in Nevada. Her clinical focus include PAD, limb ischemia, pelvic venous disease, interventional oncology, among others.
Thank you so much. Thank you, Dr. Vatkancherry. Thank you for all the organizers to have this amazing symposium, and I'm very happy to present. It is a very big topic to discuss in just a few minutes, but I'll try to give like at least some overview of aortic interventions. I don't have any disclosures. The objectives of this talk would be to introduce aortic disease, to evaluate treatment options for stable aortic pathology such as aneurysm or stenosis, discuss treatment of acute aortic syndromes and aortic trauma, and emphasize the importance of comprehensive aortic team. Aortic disease, aortic pathology includes a very wide range of diseases from aneurysm, stenosis, acute aortic syndrome, and trauma. Etiologists, most advanced age after 60 and especially after 80 years old, male gender, hypertension, smoking, Marfan syndrome, bicuspid aortic valve, vasculitis, and many other diseases that promote atherosclerosis, infection, cocaine use, heavy weightlifting, and of course trauma, most often motor vehicle accidents. One of the pathologies is thoracic aortic aneurysms, and they're usually divided on ascending or descending thoracic aortic aneurysms. Ascendings are most commonly treated surgically, and the indication for the surgery is if the ascending aortic aneurysm is more than 5 centimeters, or with a rapid growth of more than 0.5 centimeter in 1 year, or 0.3 centimeter per year in 2 consecutive years. Everyone who has ascending aortic aneurysm, their family members should be screened for having aortic aneurysm as well. Some of the, for descending thoracic aortic aneurysms, the standard of care is to treat with endovascular prosthesis, and that's where interventional radiology comes to play. In aortic arch interventions, a lot of the times we do hybrid procedures with surgery, cardiothoracic surgery, debranching vessels of the arch. They transposition the vessels from the original place of origin to more proximal aortic root. And after that, we usually cover as you can see, endovascularly, we cover the arch and proximal descending aorta with the stent. Most of the time, this left subclavian artery gives endoleak, and endoleak is just increasing, it just continued growth of the aneurysm, which I'll discuss in a little bit more details in the next slides. But to prevent this problem and continuous growth of the aneurysm, a lot of the times we coil and close this vessel. This is one of the examples of the case that I did recently. Two of the vessels were brachiocephalic vessel and left common carotid were debranched and transpositioned into the more proximal ascending aorta. After that, we place endograft right at the base, right before the origin of this new transposition graft, and then after that we coiled the subclavian artery, which initially was given a little bit of an endoleak. Abdominal aortic aneurysm, going a little bit lower now in the body, the prevalence is pretty high. It's about 10% of patients older than 65 years old, and it's even higher in a patient over 80 years old. Majority of this aneurysms are asymptomatic, and most people only know about it if they've been either screened or if they had imaging for some other diseases. And oftentimes they're found incidentally. Sometimes when they do come with symptoms, the symptoms are abdominal or back pain. They can embolize because there's a lot of thrombus growing inside the aneurysmal sac. so that clot may embolize and cause ischemia in different organs in the body, and also sometimes they present with rupture. Treatment of asymptomatic aortic aneurysms, if it's less than 5 centimeter, it is just medical management, and if it is more than 5.5 centimeter, or it has rapid growth, or if patient presents with symptoms, then the endovascular or open surgical repair is warranted. The prognosis of ruptured aortic aneurysm is very poor. About 70% die before they reach the hospital, with about 40% additional mortality for those who undergo the repair, either endovascular or open. And this is why it is so important. If someone has asymptomatic aortic aneurysm, it's very, very important to follow them in clinic, to have a serial imaging, and to make sure that if the aneurysm grows, that we actually treat it, because this mortality and consequent morbidity for those who do survive is really, really bad. This is one of the examples of infrarenal abdominal aortic aneurysm. This was not ruptured, but the patient did come in with symptoms. So the patient presented with abdominal pain. We saw this somewhat irregular saccular aneurysm. So we performed aorta by iliac. This is one of the more simplest ways to treat aneurysm. This is just main body of the endograft, and it has 2 limbs. This is one of the most common procedures that we do perform. When we evaluate the patients for abdominal aortic endografts, some of the most important things to consider, if there is any involvement of the suprarenal arteries, such as SMA or celiac, or any of the renal arteries, we do measure aneurysmal neck, which is the distance between the lowest renal artery to the sac of the aneurysm, and that is very important to seal the aneurysm. Sorry. And then we also have to evaluate the excess vessels, because as in this example, that was a very tortuous with a lot of calcification in it, which we had to pre-treat beforehand. And sometimes we have to choose the device depending on excess site that we can get. If some of the vessels are very small, especially in smaller females. This was an additional case of abdominal aortic aneurysm. In this case, it was a ruptured one. 73-year-old male presented with acute abdominal pain, hypertension, shortness of breath. The aneurysm was juxtarenal, involving one of the renal arteries and also SMA, and required a pretty significant and extensive repair. We got bilateral groin access to deliver the endograft. We also had to do left our surgical colleagues did the left axillary cut down and 10 centimeter conduit. From the conduit, we delivered 2 stents, 2 covered stents into the renal artery and also into SMA. Obviously, it sounds very easy, but it did take a while to go through this procedure, because it is crashing patient. All the vessels very spasmed. The aneurysm is first of all, it's already a big aneurysm, but also it's very difficult to do any interventions in the aneurysm that is ruptured. And then we delivered this stents and the endograft at the same time, and eventually had a really good result with preservation of all the vessels and endograft. Endoleak is a persistent blood flow within the aneurysmal sac following endovascular repair. There is multiple types of endoleak. One of them, most common one, is type 2. And we can see we had a case which on ultrasound you can see on delayed flow that the contrast comes in into the sac on more delayed imaging, and that shows us that it is delayed type 2 endoleak. In this case, we got access to iliolumbar artery from internal iliac artery. Then we got the microcatheter in the distal part of the vessel. We coiled this distal vessel and delivered some onyx into the aneurysmal sac. We had a great result with resolution of the endoleak. Aortic stenosis is another problem that we may have. It's a 30-year-old female with HIV. She presented with hypertensive crisis, acute respiratory failure, acute kidney injury, bilateral Rutherford 4 critical limb ischemia. So basically everything below the waist had some ischemia. In this case, she was not a candidate for surgery, and this is why we went with intravascular lithotripsy. We performed it with 8mm balloon, and intravascular lithotripsy is delivering ultrasound beams as we dilate the lumen of the vessel with the balloon. So the ultrasound lithotripsy performed through the balloon inside the vessel. Most of the time it is used in peripheral vascular disease, but in this time it worked really well for aortic disease. We did have significant improvement, both objectively with with improvement of stenosis and also decrease in improvement in pressure gradients. Before the procedure, patient had almost 100 gradient, and after the procedure it was only 60, which was not ideal, but it was good enough for the patient to clinically improve. And you can see on a follow-up CT that the lumen is significantly better. Her bilateral feet rest pain and left foot numbness resolved. Her hypertension was controlled with a single medication. Pulmonary edema resolved. Unfortunately, her kidney function did not improve, but that is better than all the symptoms that she came in from initially. Acute aortic syndrome is a very difficult diagnosis and is life-threatening aortic pathology. It has several clinical presentations, could present with aortic dissection, aortic intramural hematoma, penetrating atherosclerotic ulcer, traumatic aortic injury. The onset is usually severe chest pain, abdominal pain, syncope, congestive heart failure, and shock. Dissection is one of the most common presentations, and in untreated patients, mortality rate is 1 to 2% per hour. So it is very, very important to treat this patient and stabilize these patients as soon as possible. Type A dissection is usually treated surgically, and type B dissection could be treated medically or endovascularly. Especially endovascular treatment is associated with better short-term outcomes than open repair. Right now, considering there are some high-risk features, these patients usually, if someone has these features on their presentation, either on imaging or clinically, then we prefer to do endovascular treatment over just medical management. And this is how dissection looks. There is a false lumen, there is a true lumen, and it is a separation of intima and medial layers. This is just last case to show how the importance also long-term. So initially we're placing endografts just to stabilize this dissection, but sometimes with the time, this dissection false lumen can become aneurysmal, and it is very difficult to manage at that point. In this case, we had this aneurysm growing from the false lumen. We embolized it, and the patient did really well after that. The very important part for all the aortic disease is to have a comprehensive aortic team. The outcomes are significantly better for those centers where this comprehensive team is available and performs full spectrum of open and endovascular procedures. The critical components are cardiac surgical team, vascular surgical team, and endovascular specialists with extensive experience. It is also very important to have very good radiology team who can fast and efficiently describe CT, MRI, and echo findings. And it is also very important to have very fast and experienced anesthesiologists and ICU teams. So in summary, aortic pathology includes a wide range of diseases. Prevalence in population is high, and prognosis could be very devastating. Endovascular management becomes a mainstream, and comprehensive team is critical to deliver best outcomes. And I want to thank Miami Cardiac and Vascular team for giving me introduction and teaching me most of the things that I know about aortic disease. And also thank you to my current team of both surgical surgeons and the interventional radiologists in my group. Thank you.